Great. So this is an interesting case of a 69-year-old who was doing a lot of walking and felt pain and presented with 2 weeks of swelling. And so we can appreciate on the sagittal imaging how we have this stump of what is located in the region of the tibialis anterior, this full thickness, complete component where we really get to see that tendon edge, and we can guesstimate and measure that it's about 7 centimeters from its insertion at the medial base of the hallux. And when we look at this type of tendon tear, this is very uncommon to occur just from walking. We can see that the edges of the tendon were thickened and likely tendinopathic. We can see that also on the axials, very enlarged appearing tendon, even more proximally. And what we can see when we look at this foot is this exaggerated rear foot, elevated calcaneal attitude, and this horizontal positioning of the talus in a patient that has pes cavus. So he's seeing this tendon overload at the tibialis anterior in a patient who has this severe form of pes cavus. And I'm saying severe just looking at the rear foot driven cavus with the elevated angle and the apex of the deformity, at least on this non-weight bearing, appearing in the region of the talonavicular articulation. So when we look at the remaining portions of the examination, let's appreciate the medial flexor tenosynovitis. If we follow the flexor dig and the flexor hallucis longest to the masternode of Henry, we can see there's tenosynovitis located in that region, the posterior tibial tendon enlargement, the mild hypertrophic tendinosis, and the medial flexor retinaculum seen here as it's slightly stripping away from the medial malleolus. There is no tendon subluxation, but this is leading to increased stress in this location. Moving on to the lateral flexor tendons, just like in the discussion that we've had on pes cavus, we can appreciate the peroneus brevis split tear. Notice let's just zoom in on that a little bit. We can appreciate the peroneus brevis splitting it into two pieces. This is the lateral retromalleolar groove, still in two pieces as we follow it down, and then it will reform to form a common tendon insertion somewhere after the peroneal tubercle prior to the calcaneocuboid articulation. And we can see that centering in this region here, this split tear that we can even see a piece of it in that location. We'll go back up and take a look at the superior peroneal retinaculum, which remains intact. The tendon has not subluxed. And so we have now effectively dealt with all our tendons. Moving on to the ligaments in a patient that has this degree of pes CavoVarus, let's take a look at the syndesmotic region. What we can appreciate is the thickened appearance of these ligaments. They're not torn. And in fact, the fibula and the tibia are actually driven together as this person has this elevated arch. When they move to the phases of gait, they're going to place a lot of stress and want to interdigitate this particular region as they externally rotate the tibia on the talus. Moving down to the lateral collateral ligament complex, we can see this mild stretched appearance of the anterior talofibular ligament, the thickened posterior talofibular ligament, and the calcaneofibular ligament. We can also appreciate that on a coronal image, which we always like to take a look at the hammock of our calcaneofibular ligament, noticing that there are some ganglia as it attaches closer to the posterior calcaneus, and we have this subacute on chronic sprain occurring at the CFL. Another thing you can see here and appreciate that we talk about all the time, we can see the lateral talar process. Let's tunnel in on this ligament here, and we can appreciate that's going all the way back to attach just deep to the lateral wall of the calcaneus along the region of the calcaneofibular ligament, and that's your lateral talocalcaneal ligament that is sometimes well seen. Moving on to the medial deltoid ligament complex, moving to the deep fibers, we can see they're thickened and of low signal. Moving to the superficial band, we can appreciate the tibial spring, not under a lot of duress. We get to the portion of the supromedial spring ligament, and we can appreciate the thickened area here. We can see that with some volume averaging on the coronal images, but it's not easy to see there. So supromedial band, medial plantar band, inferior band. Let's take a look at that on the coronal image. That's going to be deep to our talar head. Let's move that into a place we could see it. And I'm just seeing just some thickening and mild synovitis in that region. So now we've dealt with our medial ligaments. Let's do our ropes. What we can appreciate in the region of the Achilles, we are seeing a low-lying soleus myotendon strain. We're seeing Achilles tendinosis, trace retrocalcaneal bursitis. And even if we consider about Haglund deformities in this patient that we were talking about, if we look to measure the bump and we try to exclude the bump from the posterior process, we're going to get somewhere probably around, this one is 5 millimeters. So there's a mild Haglund bump, but that is not the major issue that is causing the peritendinitis. There's this low-lying soleus and plump FHL, and the peritendinitis that's existing between them may cause fibrosis and other experience of posterior ankle impingement. Moving from those regions, let's go to the sinus tarsi and the plantar fascia. Notice the obliteration of the subcutaneous fat plane. That's a large heel pressure point. And when we look at that pressure point on the coronal images, we can really appreciate what a hard heel strike might look like as we're in this very exaggerated type of pes CavoVarus foot. So there's a very strong heel strike. When we can look on T2 weighted image to see whether or not there's any adventitial bursitis, note this is really fibrotic. It's of low signal intensity, relatively speaking, and has been replaced. So it's not fat, it's actually fibrous tissue seen there. The plantar fascia itself, what I'm seeing here is some mild thickening, not a lot of periaponeurotic edema. And when I look to the muscles, I'm pleased that there's not a lot of atrophy in the quadratus plantae or the flexor digitorum brevis or the abductor hallucis. So that is a good thing for our patient. In terms of the sinus tarsi, I'm seeing a partial preservation of the fat, no obliteration of that. And now let's move into the bony structures, and we can appreciate the subtalar articulation, posterior subtalar joint. And we're looking right now, I'm looking for an extra-articular anteromedial coalition. And I've already looked at this case, so let me just go back a second. When I'm first looking at any case, the first thing I'm doing always is looking for my talar dome injuries. Just want to make sure to spec those out and not pass over them. And as you can see, I've already marked this lateral osteochondral defect of the talar dome with cystic change and minimal edema, no focally unstable fragment. And I would give the measurements about 9 by 5 millimeter for that lesion. I would look around, obviously looking for any kind of fracture and bone marrow edema in any of these locations, seeing cystic change at the midfoot and degenerative change. Getting back to assessing my subtalar joints for coalitions, I'm looking for bony and osseous coalition. And now I'm moving into some of the more elegant areas and more difficult things to read. The posterior subtalar joint, I can appreciate the layers of cartilage. And then as I move to the medial side, I'm noticing that I'm having some poor definition of this area. I'm going to look at it, of course, on T1 weighted image, and I can appreciate that. I do have a nicely formed space. I want to understand where I am in relationship to the sinus tarsi, because that makes a difference. So here's my sinus tarsi. Here is where the sinus tarsi, the medial aspect of it is. And now I'm finished with my sinus tarsi, and I've noticed I'm already having some kind of osteophytic ridging along that roof region, and I'm seeing this extra area here. Now, there is a facet here, and sometimes it's not abnormal. So I'll be looking to see, are there degenerative changes or synovitis in this region that let me know that this is a restricted area of motion that I'm seeing here. And this is where it can be difficult to call it every single time accurately. I find it to be difficult at times, but the more I look at them, the more you can appreciate what the original authors were describing as degenerative change across a coalition. So again, here's our sinus tarsi moving towards the medial space here. Now we're moving just posteriorly to that space, and we're noticing that there's an even upslant of this articulation and degenerative changes occurring here. So although it's a small one, there is a extra-articular posteromedial talocalcaneal fibrous coalition. Moving on from there, I'm seeing some dorsal talanavicular degenerative change and some anterior subtalar degenerative change. Let's go back to our T2s and take a look, making sure that we don't miss any edema, and some midfoot degenerative change. Now, when I'm looking to understand how to characterize any kind of cavus or planus, what we're looking for essentially is to try to understand the vector of the talus relative to the navicular, relative to the first metatarsal, and also the vectors of the calcaneal attitude relative to the talus, so that we can approximate where we think Meary's line would be. So when I'm thinking about making Meary's line in terms of looking at that on an MRI, what I can appreciate is I'm going to first try to identify my lateral talar process and understand where my midpoint is. Then I'm going to try to understand where my midpoint of my talus is. And then from there, I'm going to try to understand the first metatarsal. Now, in this case, it's very hard to do because they didn't give us a lot of room in the mid to forefoot to see this area because we're cut off here. So it can be difficult to do, but we can clearly see that there's some type of elevated arch when we look at where the navicula ends and where the cuboid is, that we're less than 50%, way less, almost zero overlap in that location. So that's one of our criteria that we can use if we didn't recognize right away that this was a pes cavus case. Now notice the talus on the medial side has a declination, and laterally on the talus has a more horizontal position. And that's something that is often seen in pes cavus. Let me just make this a little smaller so we can appreciate the anatomy better. But when I'm thinking about the talus coming down, we often have this declinating, that it might be lower on the medial than the lateral side. And that has a lot to do with the plantar flex first ray and the overcompensated biomechanics. And when I have this medial column overload, what's happening in the calcaneal region is this rear foot cavus, that supination that's occurring in the calcaneus, this twisting that's occurring, where I get a medialized heel strike, but only after twisting that calcaneus. So this is the biomechanical malalignments that occur with a patient that has this severe pes CavoVarus type of foot deformity. And we can see the declination and certainly the overloading stress. Even here, you can appreciate the stacking of the midfoot in this person's high arch, where the rear foot is much higher than the forefoot, which is really the definition of pes cavus. So altogether, when I'm thinking about the impression for this report, we have a complete tibialis anterior rupture, approximately 7 centimeter proximal to its insertion. And we'll give them a measurement on that. We can give them chronic lateral osteochondral talar dome defect with cystic change and no unstable fragment, the low-lying soleus with its peritendinitis and diffuse Achilles tendinosis, the peroneus brevis split tear that we can appreciate rather nicely on this axial image, where we can see the split and give them a measurement along the level that it occurs at the center of the lateral malleolus. In terms of the medial flexor tenosynovitis, that's giving us another identification of medial flexor overload and uncompensated biomechanics. And lastly, there's pes CavoVarus, and we would want to identify that and appreciate that, correlating that with weight-bearing foot and ankle x-rays. So thank you for your time and attention, a nice corollary case to what we discussed yesterday.